Welcome to Think Like a Pancreas, the podcast. Our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in the program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Since this is a very individualized condition, please check with your healthcare provider before implementing any of the weird stuff we may happen to share with you today.
Welcome to Think Like a Pancreas, the podcast. I'm your host, Jenny Smith, and today I'm super delighted to be joined by diabetes patient advocate and health content writer, Corinna Santa Anna. You might know her online as Type 2 Musings. Recently, she participated in the International Consensus to End Diabetes Stigma, and you can find out more about the ongoing efforts to end diabetes stigma online at destigmatize.org. So I am so super excited to chat with you. I work with a lot of women through multiple different times of their life, and you're very correct in terms of how I know that, some of the things that I've read that you've put together and written so beautifully. There is a lot of misunderstanding in women's health, not only with diabetes, but just outside of diabetes in general, a lot of questions that don't get answered correctly. So welcome to our chat.
Thank you. Happy to be here.
Of course. And you were just telling me actually something just before we got recording here about a study that somebody had sent to you, or you had had a discussion. I think that would be just so unbelievably valuable to share.
Actually, it was an article that was posted online on LinkedIn, of all places. And the recent study or recent thinking is that passing on type 1 diabetes to children is more likely to happen through the father than the mother. So I haven't had a chance to look into all the details. It was just sort of saw the news blurb. But what really drew my attention to it was the conversation online in response to this article. And, there was a woman who posted that had she known this in her 20s and the 70s, she might have made a different decision about her reproductive health. She mentioned that she had had a tubal ligation because she was concerned about passing on type 1 to her children or other health complications. She was also concerned about whether or not she'd be able to have a healthy pregnancy and what her state of health would be, afterwards. So, this is the kind of thing we need to talk about openly, not just among us women.
Because what you bring up is truly still a consideration. I work with a lot of women, especially in that preconception and during pregnancy time. And the question still comes up to me over and over in that time of, I'm trying to get ready. Is it really safe for me? What are the problems that could be there for the child? I would say 100% of the time, a woman or even a couple asks me, what is the potential that I will pass on, the possibility of type 1 diabetes to my child? And there is better information today, and it is correct from a father versus a mother with type 1, much more common for the father to pass on if it is a genetic component. But I think it's still unfortunate that this is the thought that women who are planning or would like a child in their life, they're still trying to get around this idea of, is it okay?
Yeah.
And that's lack of the right information out there.
Yeah, and it's not just a consideration with type 1 also.
No.
There's people with type 2 also are told, you're at risk of complications for you and the baby. It's going to make managing your glucose levels that much more difficult. Your hormones change, your glucose sensitivity change. And that they get told that if they have a really strong relationship with the doctor who is well informed. Usually they get told, watch what you eat.
Yeah. I'm glad you make that point, because over and over, while it's very limited now for me to work with somebody with type 2 in pregnancy, previous to working with integrated, I did work with a lot of women with type 2. I also worked in a clinic where we saw a lot of women with gestational diabetes. And the lack of good information really is still astounding in this day and age. Preparing a woman with type 2 diabetes who comes to you and says, my partner and I are thinking of having a child. What does this mean for me? Most people don't even know what to ask. And that should be on the clinician's side to say, well, we have to have, these are our goals. You're on this kind of medicine. It's going to mean a transition to this type of medicine because this isn't approved in pregnancy. And you're right. That comes down to a really great provider, of which I hate saying it, but most of them are just not educated enough to have that conversation.
Well, it's whether it's gestational diabetes, type 2, type 1, it is a pregnancy that I would say has an elevated risk. That doesn't necessarily mean a high elevation, which I think is another message that needs to get out there, but it does take more managing, more, conscious, thoughtful management. And the thing that also I've run into time and time again with women who had gestational diabetes is that there's such a focus on what they're dealing with in the moment that the conversation that gets missed is the long-term implications. I know one woman has 5 children. They're all grown now, but she had gestational diabetes with all 5 pregnancies, but was never told, this puts you at higher risk for developing type 2. You need to monitor this more closely. So, the follow-up didn't happen. It was years later that she got diagnosed, and only after her symptoms were very strong. I got to wonder if she had been more closely monitored in the interim, could it have been caught earlier? Would that have led to, a better outcome for her?
Many times the outcome, whether it's gestational or type 2 diabetes, but many times with gestational especially, is they come in for that 6-week postpartum visit. There's an evaluation. They may have, again, with a really good practitioner who's been following with them during the pregnancy, they may have said, continue to do those finger sticks or keep using that CGM that they may have gotten for pregnancy. Keep using it until we follow up again 6 weeks from now. So we've got some information, some historical to kind of go on. But you're right, they miss the boat in terms of telling them this has still put you at a higher risk of type 2 diabetes down the road. So the changes you made in pregnancy, they need to be kept. We need to keep up with this. You need more frequent follow-up on this, especially if you're planning another pregnancy down the road. It sounds like you've talked to an awful lot of people about all of this. Do you have a good connection with women who've had gestational diabetes or type 2, or just in general within the community and the writings that you do just come across a lot of information?
I live with type 2. This with gestational diabetes when I had my children. Okay. Diabetes is in my family, and it's been, 15 years since I was diagnosed with type 2.
Okay.
And since then, I've been writing about diabetes a lot. So I think over time, I've just run into a lot of people here and there with this experience. It's, it's women's health is interesting to me, not just because I'm a woman, but because of it has a ripple effect. The role a woman plays in their family and as a parent, not just genetically, but also socially. If that person falls ill or has a chronic condition they have to deal with or experiences anxiety because of their health or because of questions about their health, that has a ripple effect, which is not to say it's not the same for a father or a man, but society puts women in a particular role as caregiver, as parent, as nurturer.
As a particular kind of caregiver. I think there's still a very visual, even in today's more open kind of concept of family structure, right, that we have, there's still the idea that the mother figure plays a particular role comparative to the father figure. There are different roles that you end up accepting or doing because that's how you grew up and that's what your parents did, or, whatever it is. And you're right, when you live with a chronic condition, you can see the potential impact that it has, as you said, a ripple effect on all those other things that you move through as one of your jobs being a parent. I always feel like as a parent, you have like so many things. People say, well, what do you do? Well, what do you want to know about what I do for this versus that versus career versus, right?
Yeah. Well, and society does give us a certain idea or picture of the role, and that's changing, and we have to acknowledge that also. Families don't necessarily look like what they did in the 40s, 50s, 60s, 70s, whatever.
Right.
Also, we have much more openness about people who are taking on traditional gender roles.
Right.
Or gender identification. And we need to have science and evidence-based healthcare for all of those situations, not just, some normative idea is that has been considered the standard up to now, which is a big challenge, especially since to now we're only now acknowledging the limitations of scientific research that's been done, and acknowledging the fact that women are underrepresented in clinical trials, people of color are less represented. There's a lot of complexity behind that in history that feeds that particular trend. But it's something as simple as the color of your skin affects how skin irritations and skin conditions show up. So that picture in the medical textbook might not match what's happening with the patient in front of you.
Right.
There's sort of this conundrum when they look at statistics for diabetes of, South Asians are statistically more likely to develop type 2, but they're not necessarily so likely to have obesity as well.
Correct.
And there's a big assumption that those two travel together, and one will pretend the other.
And in that population especially, it's very interesting because if you look at the differences between more westernized or Americanized and lifestyle versus lifestyle in their own cultural atmosphere, right? And the things that they're eating and their lifestyle and their habits and things, they shift considerably in our Americanized kind of life. And in terms of weight specific to type 2 diabetes, you're right. They do not fall into the unfortunate, they have to have an overweight or obese status in order to be considered, oh, you must have type 2 diabetes, when they're looking at numbers and, all of the blood work and that kind of thing. I've seen it over and over again, honestly, in working with all different types of people with diabetes. And it's it lacks the individualization that I think you're kind of in the background sort of talking about. Even skin conditions, we have to look at a person as a person, not the physician's research in a couple of data kind of bases or a couple of, cases that they've treated, and they say, well, it doesn't look like this. Well, this person, was maybe Irish American versus, you know what I mean? So there are a lot of differences in that. It really means we have to individualize on all bases of management within diabetes.
And I would also say we need to listen to the patient. We need to listen to their experience. Another thing that I run into a lot with in discussing their healthcare with women is, I told them this was going on. I told them I didn't feel right. And they're like, well, your blood pressure looks fine. Another woman I know, her blood pressure runs low. just because she's very athletic and very active. And so her body is normalized at a lower blood pressure than the standard. She almost ended up with preeclampsia because her blood pressure was high for her, but it was still in the range. Yeah. And the doctor would not listen to her when she said, "Don't feel right. This is not how I normally feel." And, they did the check, but then they didn't, they compared it to what the standard was versus what her normal readings were. It's really important to listen to the person and what they're experiencing and meet them where they're at.
Right.
Because it's, there's nothing more frustrating than not feeling well, going to the doctor, being dismissed, and, pretty much left on your own to figure it out or decide what you're going to do about it.
It makes me really considerably think about the movement, even outside of sort of that conception age within women that are beyond that, moving into their, upper 40s, 50s, or whatever, that perimenopause into menopause time. Over and over, I hear, whether somebody has diabetes or not, I've got a lot of friends who don't have diabetes, kind of entering into that time period where things are looking a little bit wonky, right? And they go to their healthcare practitioner and they raise these questions. I'm just not feeling right. This is what started. Oh, you're going into that time change in life is what they're told. But they're given nothing beyond that. Nothing to, let's look at these parameters. Let's try this. I'll have you talk to somebody more knowledgeable about this. And then when you pull that into diabetes management, it makes it even more frustrating because all of those hormonal shifts that you might have known are going to happen and you have a strategy for, once you get to hormone changes that no longer fit your model that you've established, you're left even more in the dark because nobody can help you. It's so frustrating.
It's like you have to go back to the beginning and figure it out again. Yeah. And menopause in particular, it seems like unless you have some kind of drastic condition and a really involved healthcare provider, it's sort of like you can do hormone replacement, you can write it out. Those are your options, and it seems like, shouldn't there be something more? Something in the middle, maybe. So that's another interesting time in life that, we don't talk about enough. And I think, so I watch PBS, the mystery series, and there was an episode of Grantchester recently where the wife of the policeman is starting to go through menopause. They talked about her mother, who was ultimately institutionalized. Both of them had this great fear that she was going to end up with the same fate as her mother.
Oh.
But an older woman told her, "You're going through the change. And it's, you're going to feel wonky." And she says, "This is how I dealt with it." She goes, I broke a whole set of crockery. So every time she'd get frustrated and
break a dish.
She'd break a dish. But
I think it brings up the really good point is that it brings up the sharing of experience. This is normal. Your symptoms might be different than mine, how you're feeling, how things change, but this is normal for you to be feeling. It may not need to be medicated, right? As happened in the story, but how can we work through these feelings and how can we open up the discussion? I find so many women still really almost squeamish about discussing this topic.
Well, that's how we were raised, right? Yeah. Don't discuss this in polite company. And it goes back even to being a child and not being taught vocabulary. Right? We give our body parts, especially those that have to do with reproduction and sex, euphemisms.
Yes.
Okay, so if I go to the doctor and say, well, my nunu hurts, doctor's not going to know what the hell that means.
Right, exactly. That's one of the biggest, I have two boys and I have taught them from a young age what the right name for their parts are. Even if we have little silly names, they still know what it's called. So they won't call it whatever the weird name is when they go
Yeah.
So.
Yeah. And so, but the sharing of it, that's sort of, if we can get back to sort of that communal or community exchange of, this is what's happening, it's natural, or maybe it's not natural, or it's not something I'm familiar with, maybe you should get that checked out. That's so valuable. And it also does another thing that I think is really important, is that it moves us away from stigma. It moves us away from feeling shameful about these things that, bodies are messy. They just are.
Very messy.
Anybody who's raised a teenager just knows it, right?
I'm not there yet. Almost. I'm an almost 12-year-old, so we're sort of like right on the cusp of that. So
yeah, well, you'll know soon enough. If part of being healthy is also mental and emotional, we need to do these things to support that as well. It's not just, your blood pressure's fine, your glucose level's fine, your heart is beating, your lungs are breathing. It's more nuanced and complicated than that.
Yes.
And I wish that, healthcare and how we talk about healthcare and share about our health was more inclusive of not just the physical, but also the mental and emotional. And also, like you said before, more individualized. Been watching the Paralympics the last couple of days.
Yeah.
And one of the things that really struck me was we have people of all different abilities competing in the same sports, and it's showing that what we might consider like a baseline normality, like something as taken for granted as, 4 functioning limbs, isn't the barrier that we think it is.
Correct.
It's, the spectrum of life is much wider than we're taught. And we need to start accepting that and celebrating that.
Yeah. And I think even within the realm of diabetes too, when you're talking about, gestational and type 2 diabetes and even type 1 diabetes, there is a wide range of management strategy that can work in all of those different places, right? We have so much new technology today. And thankfully, we are getting more on board with the technology not being just seen as beneficial to type 1 alone, right? That technology is slowly as it is, but it's sort of moving into the realm of, hey, you know what? Why can't somebody with type 2 diabetes, why can't somebody with gestational diabetes make the best use out of these products as well? Again, it goes back to the individual nature of what one person might need versus another person. And I think of it a lot, honestly, when we look at clinicians. And I think that I get the sense, I should say, that many clinicians you go to with a question and you can almost see them step back when you ask something that they clearly don't know how to answer, and they sort of beat around it. When honestly, what the person really would prefer and really appreciate is if that clinician just says, you know what, I don't know, but I see that you got some specific things that you need to work on or questions. And in women's health, I think that this clinician might be better for you. Or let's get a visit over here. There may be things that this person can answer well more than I can, but it's almost the worry of the loss of that care to that person that causes the doctor to say, well, it is what it is. nobody wants to hear that.
That's right. Yeah, it's like that old joke. I went to the doctor. I said, "Doctor, it hurts when I go like this." Doctor says, "Don't go like that," right?
Don't go like that. Yeah, that was always my
So,
dad's joke. Whenever we
yeah,
injured something, we were like, Dad, this hurts. Well, then don't wiggle your finger like that, or don't
yeah,
push on it. And we'd be like, Dad.
that's great. But my bone is broken, and I'm going to end
Right,
up with a crooked finger for the rest of my life if we don't
right.
deal with this. Yeah, I mean, I think also there are some very real barriers in healthcare for doing that kind of collaborative care. Insurance is a huge one.
Yes.
And that's we can't ignore that elephant in the room. Another is the doctor part of or encouraged to be part of a network of clinicians and a network that goes beyond their focus or specialty? It would be great if we could do personalized care that is integrative and, those are all the things we strive for.
Right.
Not quite there yet.
We're not. And I always think in the realm of people living with type 2 diabetes, that integration would be so very valuable in long-term health outcomes, right? Because if you can integrate into let's say this person has taken time off of work for this 20-minute visit, if they get that, again, insurance being the big thing in the room that's kind of compounding the problem, but they get this little short visit time, and then they're told, well, you need to see a diabetes educator, let's say, if they even have one that they can refer to. Well, that's another time out of work for that person to make, right? Rather than an integrated visit that says, okay, you've got 15 minutes with the doctor here. We're going to root out the things that need to be addressed. The other 15, 20, maybe 30-minute part of this visit is going to be with an educator or with the dietitian or with, whoever, or the person who's going to teach you how to start taking your injections the right way, because that's new on the list now. But we don't do it that way. It's not covered that way, and we are leaving people in a lurch, especially the underserved populations. Truly, they're being left to manage in a really poor way that doesn't work.
Yeah, and there's so many things, so many threads I could pick up on that. Something that recently happened, there's an over-the-counter CGM available now. $100 a month, more or less. Anybody with type 2 doesn't use insulin.
Use it.
You could use it. However, what support is there out there for people to understand how to use it? I mean, I'm sure, and what it means, and how can they respond, and if they don't get the results that they want, how do they avoid beating themselves up?
Correct.
And so, technology gets touted a lot as it's gonna change healthcare. It's gonna make it great for everybody. I'll just say, I'm not so certain, because we can't lose that personalized human element where people are there to help teach and learn and support and coach and, mentor and, be there throughout the whole journey, not just, oh, here's your thing. Yeah, watch the video on how to install the sensor, load the app on your phone, see you in 6 months. We're not just pushing people out the door that way.
Right. And I think that falls short in terms of the understanding in the person recommending. Because again, as I've seen, a lot of people with type 2 diabetes really don't get to start to see an endocrine practice until ever, even if they are put on insulin, they may never, ever see somebody. For the minor amount that do get into an endocrine practice, they may have a huge up comparatively. But general practice, they know a lot of information at a very tip-top level, right? They have to know all disease states and what signs, symptoms, things to look for, but they can't get into the nitty-gritty. That's the specialty job. Again, a problem with how we navigate people through our healthcare system and to get them what they really need. So if we have general practice recommending, hey, there's this new product, You don't want to do your finger sticks? Great. Slap this on. It'll collect all of your information. And then, like you said, I'll see you in 6 months. But really, we know the value of continuous monitors as I can do something about what I'm seeing. I can learn from the variables I have in my day-to-day. I can learn a walk every morning that I've started to do because the doctor told me I should walk. Gosh, this really makes a difference. I can see if I don't do it on Saturday versus I do it my weekdays. But if nobody points out bare minimums to pay attention to, you're right. The value of a $100 2 sensors a month is down the drain for that person, and they're probably not going to go back to using it.
The other thing that occurs to me is it's not just the GP that has kind of the, this stripe, the top level stripe across a lot of conditions knowledge. I've also been frustrated with specialists who, I don't mean this to be controversial, but
not at all.
So I've had the experience with diabetes nurses and CDCES, where they are very knowledgeable with type 1 and not type 2. Some of them have even fallen into, I can tell, have bought into the idea that, type 2 is a lifestyle disease, and if you just make the lifestyle changes and, it's all on you.
It's all it's a fault give, right? If you would do these things lifestyle wise better, you could turn this around. When that's not, you living with it long enough to totally understand, and all the people who have it and, that may listen or whatever out in the community can very well tell you that they may be doing all the things that they've now read about or looked at on blogs, and it's not making that much of a difference. And the unfortunate thing with educators, as you said, there are some very knowledgeable educators in all realms of diabetes, but they're not the wealth of us, unfortunately.
Yeah.
And because type 2 has the highest prevalence worldwide, we are at an extreme lack in assisting at that individual level. I don't care what kind of diabetes you have, quite honestly. I think each step-by-step you do with somebody takes working with that person to understand, what do you like to do? What's this effort? What's it worth to you? What can you do? What have you tried? And maybe even as a recommendation, changes that they can go back to their doctor with to request, hey, I've been using this medication. It doesn't seem to be doing the best. My educator recommended maybe we talk about this. But that takes somebody who's willing to dig into the weeds with the person with diabetes.
It also takes the person with diabetes having a certain level of confidence in being able to, bring up the topic, discuss it intelligently, take it back to whoever their primary care person is, and have what might be a tough conversation with them as well.
Correct.
It takes a lot. And then, and then also another area that I really wish there was a lot of improvement in, particularly around diet and nutrition, is the recognition and acceptance that not everybody eats the same.
Right.
That, we're a multicultural country, we're a multicultural world. And if you tell someone who grew up on rice, I knew somebody who was in a family of 3 people, and they were Cajun, and rice was the center of their plate. They told me once, and I was absolutely stunned, that this family of 3 went through 25 pounds of rice in a week. Which I don't know if I completely believed him, but just, the idea that you would buy a big bag for that few people and it would be gone that soon.
Yeah.
So you can't say don't eat rice.
No.
That's not going to work.
It's not going to work. It's again, it leads back to that word of individualization. It really does. And starting, when I get to work with people, we always start, where are you? What's your understanding? What do you want? Where do you want to get to? And what needs to be kept because it's part of your culture, it's part of your family structure, it's part of just it's what you like to do. If you want to eat a chocolate donut every Saturday morning because that's what you grew up doing with grandpa and it's just stuck, we have to figure that out, right? Not a no, you can't do this anymore.
Yeah.
It's my job to be able to structure it and, and help with that. But again, in terms of what you mentioned before about type 2 and educators, I think what I've found in many more of the brick and mortar established and more accredited programs for type 2 diabetes education, it really is a host of a checklist that they have to make sure that they hit. Which, as you know, well, I always think checklists don't individualize anything. It's just yep, I talked about that. Yes, we got to this point. I taught them about carbohydrates and it's all done. Move on to the next. I think it's a huge loss to the person. Absolutely.
Yeah, I mean, but also the other thing is it's a huge ask of the provider. One of the first consults I had with a dietitian was somebody, I was living in Hawaii at the time, somebody on the mainland. And they were asking, okay, so what do you eat for during the day, blah, blah, blah. And I said, well, for lunch, I often have bento. And she had no idea what that was. So that sort of brought the conversation to a dead stop because she didn't have any reference point. Even if I described it, she wanted the description in terms of how many ounces of rice and what is a pickled plum and how much of that and what's in, said you had teriyaki beef, but what's in the teriyaki and it was.
And your response is, I don't know. I'd have to go and ask the chef. And that was 3 weeks ago. Well, I really don't know.
Yeah, I mean, I can tell you generally, it's got sugar in it. It's like a barbecue sauce.
Right.
Should I be eating it? Well, maybe. Anyway, so it is at the core of it, there's a lot of frustration. There's a lot of barriers, but we can't, again, I go back to the people. We can't lose sight that everybody involved is a person. And well, it may be frustrating, I work really hard not to blame people and get, angry with people and their limitations, including my own. But that doesn't absolve me or anybody else of the requirement that we try to make it better.
Right. And to improve the situation, what do you think can, as a stepping stone, help to make it better? I always feel like, gosh, it's such a huge take on that our healthcare system in general, it's broken in many ways. And I think it would take a really big revamp of a whole system. Where can we start on a bottom level, especially within diabetes and women's health and everything that surrounds the navigation and making it easier to talk about and destigmatizing things? Like where do we start?
Start with conversation. I mean, I think it both in and outside the doctor's office. And I think, we as patients have to be a bit more demanding. If a doctor is dismissive, then, ask again, go find a different doctor, find some other resource. These days, there's more resources available remotely than there used to be. More
telehealth and everything available.
Yeah, that was one of the silver linings of the pandemic was telehealth has become more common, more accessible. Also, I think for patients, I would say, lean into the patient community online and locally, realize.
And that's one thing in the online community I've seen a lot of ask. And again, I'm much more in the type 1 sort of community, but I still linger into some of the online groups with type 2 specifics too. But there's a lot more communication. I mean, I've had type 1 for 36 years, and I know my parents would have loved to have somebody else to be able to communicate with than the doctor. I know that they would have loved to be able to have a community component to be able to reach out and say, hey, is this normal? Like, should I ask
Yeah.
somebody else about this? Or what about this new thing? Or have you tried this or heard about this? So our community aspect is definitely so valuable. And when you find providers by asking, that makes it even better, especially if you have access to that particular.
Yeah, I mean, it's like any community. Ultimately, you have to decide whether the information given is useful to you or not. It's very tiresome, the people who have found Jesus, so to speak. They have found the treatment, they have found the approach, and it works for them, and therefore it absolutely will work for you. Um, and there's also it's heartbreaking when bullying happens and
Yes.
one person or one group decides they're more worthy than another, and they're going to point it out again and again and again, or want
Or that
to.
way, that their way is absolutely 100% the way that everybody should be doing it, because see how good it works for me.
Yeah.
Yeah.
And it's sort of like, okay, you're a universe of one.
And N of one is what I always say. I had to explain that not too long ago to somebody. I said, my N of one, and they were like, I don't, N of one? What is that?
Yeah.
My universe.
Yeah. But yeah, I mean, I think that's, structurally, yeah, there's a need for healthcare reform in our government, in our regulation, in our economy of healthcare. I think that they ultimately, what I see is that there's sort of this butting of heads. There's a group of people who see healthcare as, it's a human right. Everyone should have access. Everyone has the right to a healthful, comfortable, enjoyable, fruitful life.
Right.
And so they see healthcare in one particular way. And then there's the structure of healthcare with all its competing forces around economics and profit and regulation and requirement. And they see healthcare in a very different way. And so I think a lot of what we experience and what gets played out is that conflict between the two. If everyone was humanistic, we'd have, some sort of universal healthcare.
We would. Yeah.
If everyone was capitalistic, we would only have, private healthcare and insurance. Instead,
And beyond that, I think in restructuring, we also need to start working on much more preventative care. Right?
Yeah,
we are a system that treats once there is something, and we treat more, and we add another thing. And we have a nation that has some of the best emergency care in the world, but our statistics worldwide continue to go downhill in terms of wellness because we don't teach wellness.
Yeah. And I would argue that it's not so much preventative care, but it is fostering and supporting healthful
behavior,
life, environment, removing toxicity in the environment, building communities that have open space that's safe, that have access to raw food, that have access clean water, clean air, education.
Yep.
And not just reading, writing, and arithmetic, but also we used to teach home economics. We used to teach health. We used to have physical education. Building community around things like, sports, and not sports. Oh, you're going to grow up to be a football player and make $1 million, but sports and, sports and band and clubs and community service, so that you have connection to other people and you have a collective experience, and you have something, you have emotion and experience beyond simply taking in media or being isolated or, you know, being criticized,
Right.
much more positive experience. And, that goes beyond preventative care. That goes to how do we live as a society?
Because a lot of those things that you mentioned really do teach healthful living, right? Things like knowing how to actually cook your food,
Yeah.
home ec, right? Things like even just knowing how to take a walk or how to run, or those kinds of things are now more elective. You can choose to do them,
And
but they are
elitist.
right. They are absolutely.
Yeah.
And so, we have a community of people who no longer knows what it means to look at an item and say, this is food and this is not really food. It's going to put something in my body, but it's not as nourishing as what this could be over here. If I was going to choose anything different, like career-wise myself, I'd still go nutrition. That's just a big part of my love, just overall wellness and nutrition and food. But I would go back and actually do much more within starting a plan of health education and understanding of what nutrients you put in your body do for your physiology long term from kindergarten through high school. There would be an established plan of climb in information so that you knew by the time you got out of high school why this versus that. What should I be doing to further, that's kind of that preventative model, but starting in a different way, I guess.
Well, and I mean, I look at societies like the Scandinavian society gets touted a lot as they're happy, they're healthy, and even moving from Hawaii to the Pacific Northwest, I see a big difference. And here there's a lot of outdoor activities. Everything, as simple as walking in the forest or along the river, to full-on snow camping and skiing.
Right.
And um and there's a lot of people who are very active in those ways. And the community, the cities and counties have built infrastructure, and the state have built infrastructure to support those kind of activities. So you don't have to pay. You can pay, I think it's $35 a year to get a state park pass, which lasts the whole year. You don't have to pay an entry fee every time you go. In some places, public transportation will actually drop you at a trailhead. Those kinds
Wonderful.
of things. And people here seem very, sort of oblivious to it, like it's always been that way.
Right.
And they don't understand, or they don't acknowledge or see that that's the kind of action that builds a healthier society, a healthier community.
Right.
And these are things we've known since like Edwardian and Victorian times.
Yeah.
So at some point we forgot about it or decided it wasn't important anymore, which is baffling to me. It's like in some aspects, we've come so far ahead with technology, but in other ways, we've gone backward.
We have.
In terms of our infrastructure and societal infrastructure and community infrastructure.
Yeah, and I mean, lots of roundabout, honestly, in terms of what it all leads to when you're trying to manage, a condition like diabetes. You live more where you live and you have access to these types of things. And it's just been, as you said, sort of part of the nature of the area. You don't even think twice about it, but you move someplace else that no longer has that built-in component. I mean, I live in sort of southeast the Madison area in Wisconsin, and we have bike lanes that are designated. Yeah. We have lights for the bike lanes. We have trails galore and parks and everything similar to you. And it's just part of the community. But when you leave this area and go someplace else where that structure isn't built into just day-to-day access, really, it becomes hard to seek it out. Or you lose that because you know, now you're onto something else and it's a different path in your life and you forget how to look for those things. So I think there's a lot of things that definitely we could navigate and change. We could just get on a board together with many other smart women.
That's right. That's right. If we ruled the world, it'd be a different place.
If we ruled the world, my goodness, it would be a different place. Yes. So
yeah. But I think, all of it seems like, and it's easy to dismiss as, oh, that's pie in the sky. That's, that's not really, have we lost the focus on diabetes? And I think not. I think it's, part of managing diabetes is managing life. It's managing your health. It's everything. And, if it was simply a matter of, taking a shot of insulin and everything was good, then this would all be, ethereal. But it's not. And it's about how we, nurture and nourish and move our bodies as much as it is about how, if we take a particular injectable or medication. And so we have to think about these things.
We do. And we have to become, as we've kind of just said over and over, you have to become very vocal. If somebody doesn't bring it up for you and you know enough to ask a question that doesn't get answered, you keep asking the question and you keep asking for the next person to ask the question too, because that's so important to understand for your own health management, right? So we just, we have to, the bottom line, we have to keep talking about it, right?
We do. It's when you live with a chronic condition, it's almost like you get an extra job, whether you wanted it or not. And that job is to, really understand what's going on with your health and, what's available to you to manage that and, what the possibilities are, and then pursue the ones that make sense to you.
Yes, absolutely. Absolutely. I think I always consider, diabetes, as long as I've had diabetes, I still consider it it's kind of like a child that never really grows up. Right? Like you can never really completely send it out of your house, and you get a call maybe like once every other week that's just like, how you doing, mom, or whatever. Oh, it's more like maybe like an 8 to 10-year-old all the time.
Smith, we need you to come down here.
Yes, exactly. So, I don't know. Any final thoughts that you have or anything final that you'd like to share?
Well, I mean, I think that, there's always hope. And
there's always hope. Yes.
There's always hope. And the thing I found is that, ultimately I am responsible for my health and what I do to manage it. However, I don't have to do that alone. And I do better and it's easier when I don't try to do it on my own. That when I do reach out to other people who know more or have experienced more or just have a different perspective. And that's part of why I keep saying we need to talk about these things. We need to make contact and learn from each other.
Absolutely. Thank you so much. That was such a great, just cumulative of it all. Our own healthcare, no matter what you navigate, it is ours, but we have to have the ability to share it, to gain more information, and you can do that by then turning outward to get that, to bring it back to focus in the best way that's good for you. So thank you so much. I really, really appreciate your conversation and just discussion today. And honestly, for everybody within our integrated diabetes clinical kind of staff, I wish everybody had been able to have a chat with you because I so enjoyed this.
Oh, well, thank you. It's been my pleasure.
Well, wonderful. I hope to chat with you again at some point in the future. Thanks again.